when I was sort of thinking about which case to present today, about safety of biologics, that I'd actually rather present a couple of things. Maybe they're not sort of complete, but it's really a couple of things that happened to me sort of in the course of this year. And it was a couple of patients who really sort of showed me again that we work with these drugs all the time, and yet they have a number of risks. I think we do try to be vigilant all the time, but certainly they keep on surprising us. Now, this patient is a 32-year-old patient who I didn't diagnose with ankylosing spondylitis. I saw him for the first time last year, but he, on questioning him, started with a very typical history of inflammatory back pain. 21 years old, diagnosed with AS in 2006, and he became progressively worse, and he started on adalimumab in 2008, and he, according to him, did very well. He was, before the time, unable to do anything. He was sort of working, exercising, and all sorts of things, and as I say, did very well. Then in about May 2011, he had a gastroenteritis infection. He missed several doses of adalimumab. His disease flared at that stage, and just, sort of what one usually does, sort of did whatever we could. I gave him some cortisone and it all settled. In October, he came in again with another sort of flare of his disease. He had a very painful ankle. When this guy does a disease flare, he does it properly. He comes sort of crawling in with very swollen joints. So a very painful ankle. His chest was sore, elbows, hands. And then in November, he again had a flare, but at that stage, he was also complaining of fever, which was definitely documented. Knees, one elbow, very severe sacroiliitis, and for the first time he had a raised CRP, and nothing else much on blood tests. But again, sort of gave him another dose of cortisone, and he actually settled. At that stage, we also sort of, I did speak to him about, are we going to carry on the adalimumab? Are we going to change? Are we going to do something else? But he wasn't keen to do anything. But in January, he phoned me one Saturday and said he is now really short of breath. And this guy was, as I say, exercising, getting himself, he was training to do the mid-mile mile. He's a swimmer, he loves that. And he'd been out training the Monday, and the Thursday he felt he couldn't swim. He couldn't do anything. He was generally unwell. And his chest x-rays showed a widespread reticulonodular interstitial infiltrates. And then when I sort of asked him about the previous times that he'd had these flares of his disease, he actually produced a set of x-rays, because he kept on phoning me and saying he'd already been to see his GP, he'd had all sorts of tests, because when he had the fever and so on, they checked him for his lungs, whether he had any sort of urinary tract infection, things like that. And the x-rays that he produced that had been done in September, he had the same picture that we then saw in January. Anyway, a CRP, which was also raised, but a low procalcitonin, very little else, sort of a slightly raised gamma GT, serum ACE, which is about 1.5 times the normal. And basically, excluded TB. He didn't actually, we couldn't culture anything, we couldn't find anything on PCR. And excluding other things made a diagnosis of sarcoidosis. Now, unfortunately, the pulmonologist that I was working with, we didn't get a biopsy as such. So yes, the case isn't entirely, as I say, worked out as far as that was concerned. And he was obviously started on cortisone and did very well. Unfortunately, now he's doing not as well at this stage in terms of his underlying joint disease, as the cortisone dose has been reduced. So looking at the literature, there have been a number of cases described of sarcoidosis being induced by the TNF blockers, but then also sarcoidosis looking like ankylosing spondylitis. So I'm not quite sure, and we want to then obviously try to get a biopsy and take a look further at this. But that was, as I say, one of the cases that I saw. Another patient who, 49 years old, long-standing rheumatoid arthritis. She in fact started on infliximab many years ago, and unfortunately developed septic arthritis in a prosthetic joint, also in fact about 5 years ago. And that was treated, cleared up. They didn't take out the prosthetic joint, but she really does very badly without her TNF blocker. So did decide with the orthopedic surgeon that was treating her to start her carefully on etanercept, and she actually did very well. She, though, in December developed a rash which was on her just lower legs, was very severe, and it was biopsied, and she has erythema nodosum, and probably because of the patient that I've just told you about, I did go and take a look whether there were any other reasons, or whether she had something like underlying sarcoid, but her chest x-rays were normal. But she has a serum ACE level which is at least 2.5 times the normal limit. So she's been given some cortisone, and we'll see how she does. She's been doing okay at the moment, but to see what happens to her further. Another patient, 65 years old, he in fact also had sort of fairly long-standing rheumatoid arthritis, did very well for many years, was one of those that you sort of just saw every 6 months and was perfectly happy, but then started having more and more flares, did progressively worse, was starting to sort of really affect his function, and I then started him on etanercept in about July 2011. And then in November, he went to go and visit his family in Australia, and he says he got sick there, and when he came back, rheumatologist sent a note saying, but this guy has interstitial lung disease. And he then unfortunately became worse. Obviously, the etanercept was stopped, and he was aggressively treated, but he in fact died due to his respiratory complications early this year. And then just another patient with juvenile arthritis, also been on infliximab for probably almost 10 years. And unfortunately, due to sort of problems with her medical aid, there was a delay in authorization, and she missed, in fact, not a dose, but a couple of doses. And in fact, had then restarted her infliximab, but she actually already lost the sight in her one eye due to uveitis as a child, and she developed a very severe episode of uveitis sort of around the time of reinstating the infliximab. So not sort of knowing really whether it had been to do with the use of the TNF blocker or whatever, but she has been treated now mainly with steroids and so on. So these were a couple of cases, as I say, just within literally the last couple of months, that just again to me brought back where we stand with these drugs, that really they always can challenge one and make one sort of wonder again about what we're doing to our patients. On the whole, though, I think our patients do well, but they certainly keep us on our toes. Thank you.